Malaysia's healthcare service. Malaysia Health Service is split into two developing sectors. There is a government-controlled and supported community sector and a prosperous, marketable sector that has risen meaningfully in the previous quarter century of the world. Nearly all doctors, however, are anticipated to serve in the government sector for at least 3 years to ensure that the society is adequately covered. Malaysian people pay for public healthcare through regular consumption taxes. The government does not have a reciprocal healthcare policy with any other country, thus the modest fees under this public system are exclusively relevant to Malaysian citizens. Foreigners are entitled for government health services only if they pay additional costs or they must secure their own personal health care. The Ministry of Health Malaysia's site has a different myriad of treatment fees for foreigners at government hospitals. The Malaysian government claims to be devoted to ensuring that every person in Malaysia has entries to first-class healthcare that is provided through the Ministry of Health, through the clinics and hospitals government everywhere in the nation.
Psychological symptoms among healthcare workers handling for COVID-19 patients in Malaysia. Healthcare workers serve as a frontliner against the COVID-19, and this puts them most at risk of infection as they attend to numerous patients with unknown status. The mental issue have been recognized among healthcare professionals, and several studies have demonstrated a higher burden of depression, anxiety, substance abuse, suicide, etc. among healthcare workers. Based on previous studies, work experience play an important role for healthcare workers in dealing with a pandemic. Immense pressure and long working hours can be one of the causes of stress among healthcare workers, which further affect them mentally, physically, and emotionally. A study found that people who work in an environment with higher workload and excessive pressure are more at risk of depression and anxiety compared to those who work under low psychological work demands. Specifically, healthcare workers who were transferred to COVID-19 frontline units were most stressed, anxious, and depressed compared to those who were not.
Okay, we go to the next article. Okay, this article was discussed about patient waiting and also consultation time in primary healthcare clinic. Okay, in this article, the authors also have mentioned about the strategies on how to improve this issue. Actually, this issue is very common, very famous, and always relatable with the healthcare services in Malaysia. Besides that, in this article, the authors also mentioned about the constraints and also the cause why this issue happened. And then the authors actually very clearly when they wrote this article, because they included the real strategies which they do their research at a primary care clinic for 4 weeks. So overall, this issue was the real strategies, and then they go to the clinic and to do the research about this issue. Alright, now we go to the discussion of the article. Okay, in my opinion about this article is very useful and also give a big impact on to the readers. Like I mentioned before, this article is a hot issue in the healthcare, so they will find the strategies on how to improve or solve this problem. Moreover, the authors also do some research at primary care clinics that I have mentioned before. So it does not have any issues on this. From what I have read, the authors all targeted the community among researchers, students, and especially healthcare workers. Because from this article, they will learn on how to improve this issue and then learn something new.
Okay, the third article, breaking down the barriers, understanding migrant workers' access to healthcare in Malaysia. So the summary of the article is, in Malaysia, the accessibility of healthcare services to migrant workers is controversial. Foreigners' medical bills at public institutions have recently been significantly hiked. Undocumented migrants are not covered by mandatory health insurance, which slowly covers public hospital admissions. They investigate the obstacles to healthcare access experienced by both documented and undocumented migrant workers in Malaysia in this article. There were numerous complex access barriers identified, many of which were beyond of healthcare sector's control. In light of the recent spike in medical expenditures, their research reveals that government-mandated insurance for migrant workers is insufficient. Undocumented migrants are essentially denied access to public healthcare facilities due to a perceived close working relationship between the Ministries of Health and Immigration. Language limitations may have an impact on migrant workers' quality of care by unwittingly causing medical errors and preventing them from giving properly informed consent. The discussion of the article. In light of recent increases in medical fees at public hospital, the Foreign Workers Hospitalization and Surgical Insurance Scheme, which SPICPA, SPIKPA, insurance is insufficient. In addition, if hospital expenditures surpass the 10,000 ringgit Malaysia insurance limit, migrants must pay the difference. Workers with unpaid medical expenses will not be able to renew their work permits once they expire, and their companies will be placed on the Immigration Department's blacklist. Employees are responsible for paying healthcare fees, and migrant workers frequently abandon hospitals before being released. Many businesses, as evidenced by their findings and other examples, send workers home rather than face costly hospital bills. Furthermore, migrant employees perceive discrimination, particularly when required to present registration paperwork at healthcare facilities. Discrimination based on documentation status, which undocumented migrants see as a stigma, has been recorded in a variety of circumstances. Nonetheless, as required by the Immigration Act, the Malaysian Ministry of Health directs all health practitioners to report the presence of unauthorized immigrants to the police.
Okay, next I will proceed with the fourth article for issue in healthcare delivery in Malaysia, which is the healthcare gap in rural Malaysia, written by Dominic J. Falcon. Malaysia has made great progress in enhancing healthcare services during the last several decades. Unfortunately, providing excellent and accessible healthcare to rural communities remains a concern, prompting Malaysia to look into alternative healthcare delivery methods for rural populations. The current situation of rural healthcare in Malaysia is examined in this article, along with the potential solutions for bridging the health gap between urban and rural communities. One of the issues that has been discussed in the article is primary healthcare providers are supported by the government rather than private sector. But since physicians in Malaysia are preferring to work in private sector, that lead to fewer accessible doctors and specialists in rural healthcare hospitals. This problem resulting in fundamental delivery disparities between urban and rural locations. One of the ways that can help close the gap is using telemedicine, which is it has the potential to make healthcare more convenient without the need to build new facilities or relocate physicians against their will. It allows rural residents to meet with specialists without incurring high travel costs, enhance patient communications, facilitate better record keeping, and encourage doctors from private sector to approach to rural residents without having to establish a costly hospitals. These rural communities are limiting Malaysia's economic progress. Thus, improved health initiatives are needed to close the gap in healthcare.
To sum up everything, Malaysia indeed has a number of skills for other healthcare systems, both positive and negative. The government's lengthy policy of universal health insurance has fostered an attitude of superiority to free healthcare, finding it challenging for the Ministry of Health to collect or increase co-payments for essential public services. Malaysia has unsuccessfully participated and catered its quickly growing private healthcare division that has since stretched into the municipal areas and permits individuals by larger procuring capability to prefer private doctors and hospitals instead of the government, parting the government sector with lower class and burdened patients. The residents' mandate for health services will remain to ascend as the country approach developed nation status and social class, and newfound disease alterations occur, and as newly discovered technology develops involvement possibilities.